Start with the preoccupation with failure. We are building processes to be successful. We're building a process that we think is going to deliver that ideal outcome. We know that there are humans involved throughout. There are systems and technologies involved throughout. So we're paying really close attention to indicators that there could be a failure or is a failure. So we're focusing less on the success because that's our expected outcome and more on what broke down. How do we understand the why behind the breakdown and how do we fix it and remediate it for the future? So that's what that principle means, is that we're not just celebrating success, but we are missile focused on where we have opportunity or actual failure. Reluctance to simplify interpretations, but it could be more clearly stated, right? We don't want easy explanations. We don't want to rush to a quick answer because we have an answer. We want to study it and make sure that we truly understand the full context behind that error or that breakdown, and we're solving with reliability. So not just getting an answer, but making sure we get to the right answer. Around operations or sensitivity to operations, we recognize that care is delivered at the front line, not in the boardroom or within the safety council. We have to pay super close attention and be in touch with the actual front line where care is delivered to understand how well our processes actually work. And if it's because we've built a process, for example, that was great on a whiteboard, but when you actually try to put it in place, it doesn't function very well, it's the front lines that will help you solve that. The fourth was that commitment to resilience. We want to make sure that there's capacity to redesign, or I should say respond first. Redesign is needed, adapt along the way, and make sure that we rebuild and we perfect our systems so that there's resilience and redundancy embedded within. The deference to expertise speaks to where is care delivered and who is the most knowledgeable person about that process. It may be the cath lab technician. It may be the person in sterile central supply who understands how a system broke down versus the VP of operations. Let's get to the place where the care is delivered, where the execution happens, and where the failure can occur if it's going to, and really lean into those frontline experts, people that are closest. That's all conceptual. Is at the end of the day, where do we place the accountability? Who do we hold accountable? Who are our subject matter experts? And are we committed as an organization to truly studying, to recognizing potential, actually seeing failure, and really wanting to understand why behind it and fix it?